Hello, and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the AASLD. I am Chong Tran, a transplant hepatology fellow at the University of California, San Francisco. This presentation is part of the AASLD video series, How I Approach It, COVID-19, and the Liver Clinical Dilemmas. Today's talk is entitled, How I Approach It, COVID-19 in Patients with Acute Liver Failure. We want to discuss the data and considerations in the management of acute liver failure patients who also have COVID-19. We will go over expert and consensus recommendations on the management of acute liver failure in the setting of COVID-19. And lastly, we will also discuss current recommendations regarding the pursuit of liver transplant in the setting of COVID-19. Our patient is a 20-year-old woman with no underlying liver disease who presented to the emergency department with 3 days of subjective fever, progressive fatigue with mild shortness of breath and dry cough. She denied any abdominal pain, nausea, vomiting, diarrhea, or skin rash. Over the last month, she has been taking an herbal supplement for weight loss. Her vital signs were normal with an oxygen saturation of 98% on room air. Physical examination reveals mild hepatomegaly with a smooth liver edge, and the patient was noted to be mildly lethargic with asterixis. Laboratory findings were significant for a WBC of 16, a LT of 2,950, a ST of 3,045, total bilirubin of 1.3, and INR of 2. Her inflammatory markers were elevated, and her arterial blood gas was relatively unremarkable. The patient's rapid COVID-19 test was positive and confirmed by PCR. She was admitted to a negative pressure ICU bed. Laboratory investigation for etiologies of acute liver failure, including infectious, toxic, and autoimmune causes, was otherwise negative. She had an abdominal ultrasound with normal vasculature. A chest CT scan showed mild left lower lobe atelectasis, otherwise unremarkable lungs. She also received a head CT scan which showed no acute intracranial pathology. She was diagnosed with acute liver failure secondary to weight loss supplement-induced hepatotoxicity. The incidence of elevated liver enzymes in hospitalized patients with COVID-19 vary widely in the published literature, ranging from 14 to 58%. Most reported cases were mild liver injury. The incidence of severe liver injury and acute liver failure is rare. A retrospective cohort study of over 2,000 patients from New York showed that severe liver injury, defined as transaminases greater than 5 times the upper limit of normal, was only 6.4%. Most cases were transient with mild symptoms and resolved without specific therapy. Agents used to treat COVID-19, particularly remdesivir and tocilizumab, may be hepatotoxic. However, the extent of injury is mild and rarely requires discontinuation of the agent. Finally, in many cases, it may be difficult to distinguish whether the liver injury is due to the SARS-CoV-2 virus itself, one of its complications, such as hypotension, myositis, cytokine release syndrome, or drug-induced liver injury due to a therapeutic agent. We must recognize the importance of determining the underlying etiology of acute liver failure, even though it may be difficult in patients with COVID-19. In this particular case, the most likely etiology of acute liver failure is drug-induced from a weight loss supplement known to be hepatotoxic. Furthermore, the patient's COVID-19 symptoms are mild, with no evidence of severe pulmonary involvement, suggesting against SARS-CoV-2 as the basis for liver injury. In the setting of acute liver failure, it would be risky to start this patient on a medication that is potentially hepatotoxic. Fortunately, this patient's COVID-19 symptoms are mild and likely will not require specific therapeutic agents other than supportive care. In summary, in patients with acute liver failure and COVID-19, we recommend careful determination of the underlying etiology of acute liver failure, as this will greatly impact overall management. Management decisions for both COVID-19 and acute liver failure must be carefully considered on a case-by-case basis. In severe COVID-19 cases, we recommend starting therapeutic agents as appropriate, even in the setting of mild liver injury. On the other hand, in the setting of severe liver injury, with or without the development of acute liver failure, we recommend against starting any therapeutic agent for COVID-19 that might be hepatotoxic. After admission to the ICU, the patient was started on N-acetylcysteine infusion. Despite close monitoring and supportive care, her condition worsened. Her INR increased to 5 and total bilirubin increased to 7. Her encephalopathy worsened to grade 3 on the 4th day of hospitalization, requiring endotracheal intubation. Repeat brain imaging showed mild cerebral edema. Due to her worsening clinical course, the need for liver transplant was considered. Data regarding the safety and outcome of liver transplantation in patients with COVID-19 are limited. A case report from China described a 37-year-old patient whose post-transplant course was complicated by COVID-19 infection, requiring respiratory support with high-flow nasal cannula. The patient eventually recovered after a prolonged hospitalization of 2 months. The potential for transmission of SARS-CoV-2 via solid organ transplant is unclear. There has been a case report of COVID-19 infection in a 6-month-old patient 4 days after living donor liver transplant, and the donor was subsequently found to have COVID-19. The patient suffered hepatitis as well as respiratory symptoms and required prolonged hospitalization. Organ donation in SARS-CoV-2 positive patients is currently not recommended. Liver transplant in SARS-CoV-2 positive patients is also not recommended. However, emergent indications such as acute liver failure warrant proceeding with transplant if it is the best option after careful consideration. Lastly, there are also ethical considerations surrounding liver transplant, such as utilization of resources that might be scarce during a pandemic. A decision to defer transplant in a patient with active infection may seem simple and obvious, but clinical dilemmas arise when transplant might be the only life-saving intervention. There are many questions that we currently do not have answers to, including the risk of COVID-19 severity post-transplant, the effect of immunosuppression on COVID-19, and the safety and exposure of staff in the peri- and post-operative settings. Patients with acute liver failure typically have a good 1-year survival. Our patient's liver failure, however, has worsened over the hospitalization. Based on the acute liver failure study group model for predicting 21-day spontaneous survival in patients with acute liver failure, which is a model using grades of encephalopathy, underlying etiology, vasopressor requirement, bilirubin, and INR. This patient's predicted spontaneous survival was 14.39%. In summary, due to lack of evidence, we recommend deferring liver transplant in SARS-CoV-2 positive candidates and donors if possible. However, in the setting of an emergent indication for liver transplant, such as in this case, the patient should be considered for liver transplant, especially if there is no evidence of recovery of liver function. Lastly, discussions among a local multidisciplinary transplant committee, including transplant infectious diseases, is essential, and resource utilization and associated ethical considerations should also be discussed. Back to our case. The patient underwent expedited evaluation for liver transplant. Fortunately, her condition started to improve. Her liver enzymes began to trend down, with improvement of her INR and mental status. On the 6th day of hospitalization, she was extubated. Repeat head imaging showed interval improvement of cerebral edema. She was eventually discharged after 12 days of hospitalization with close monitoring, and her liver enzymes eventually normalized. On behalf of all of us on the CLD team and the AASLD, I hope you found this case discussion on the management and consideration of patients with acute liver failure and COVID-19 useful. For more information about liver disease and COVID-19, please visit us at www.cldlearning.com. Thank you for watching.